Good evening. Welcome to another episode of Cerebral Angio reading session from Stroke Academy.
The case is of a 60-year-old female. She already had one episode of dysarthria in 2019 and was diagnosed to have left MC territory infarct. She's also having diabetes and hypertension. CT angiogram was done.
Shall we read the CT angiogram? This CT angiogram was done in 2019. Read the CT angiogram.
It is an arch of aorta.
One of the main point which everybody should remember is when you are doing a CT angiogram for stroke, always include the arch of aorta also, because of two reasons. One, we should know the origin of the main vessels from the arch of aorta, based on which you can decide whether intervention is feasible or not, or the technical difficulties if there are any anomalies in the arch of aorta. Second, whether there is any large atheromatous plaque which is there in the arch of aorta, which might be the cause for the stroke. So always tell the radio technician to include the arch of aorta also. So this is the arch of aorta. Clear? So now we'll try to identify vessels one by one. As we discussed earlier, this is the right side and this is the left side. Which is this vessel, which is the first vessel arising from the arch?
Right to brachiocephalic trunk.
This is the right brachiocephalic trunk, and from which arises the brachiocephalic means it is going into the brachium, that is the upper limb, and the cephalic, that is to the brain. Which is this vessel?
Right subclavian.
This is the right subclavian vessel. This vessel which is arising here,
that is right common carotid.
Right common carotid artery. And you can see one small vessel which is coming behind. If you trace this vessel back, it is arising from somewhere here, from the right subclavian. This is the vertebral artery. Vertebral artery. So now you can trace the right. As we discussed earlier, the dictum is you trace one vessel at a time. Then it will be easier to identify vessel, because this is a 2D picture. Vessels will be overlapping. This vertebral artery is lying far behind it, but it is overlapping exactly on this. So you might confuse one vessel for the other. So the main dictum is you follow one vessel at a time. Now we will trace the right common carotid artery. This is the common carotid artery. And here, which is this level approximately?
Lower border of C4.
Lower border of C4 vertebra. So on a radiograph, you can identify the bifurcation approximately corresponding to the lower border of C4 vertebral body. Here it divides into two branches. One, the internal carotid and the external carotid. Now you trace the internal carotid artery. Now here, when you reach here, you might think that which vessel is which. You might get confused. So stick to, you know that this is the internal carotid artery, this is the petrous area. So you trace this vessel down, you know that this is the internal carotid artery. Now it is very clear that this vessel which is coming like this is the vertebral artery. Understood? It is very clear. Now you trace it up. You can see that this is the cavernous loop, divides into middle subdural artery and the anterior subdural artery. But here there are certain artifacts here, so we can't make out much here. Now come to the second vessel, which is this vessel which is arising directly from the arch of aorta. Left common carotid artery. So this is the normal origin of the left common carotid artery from the arch of aorta. It goes up, and which is the third vessel?
Left subclavian.
Left subclavian, which is continuing as a subclavian artery, from which arises the vertebral artery on this side. Now what do you see here? This is the origin of the left internal carotid artery. It looks on CT angio that there is a significant stenosis of this was done in 2019. The patient was, and what do you see on top? This is continuing as the internal carotid artery. This is the petrous area, goes up and divides into middle subdural artery, anterior subdural artery. You can see both ACS arising from here. Clear? And you see the branches of the external carotid here. And in the back, you can see the vertebral artery coming like this and going like this, joining together to continue as the basilar artery. Is everything clear?
Yes.
So based on the CT angio, this impression is there appears to be at least an 80% stenosis of the left internal carotid artery. Now, 2 years later, that is in 2022, she was doing fine on this, and now she has come with, this is another picture. Now she has come with a recurrence of symptoms. Mild, what was the recurrence?
Dysarthria.
Mild dysarthria.
Two
Not
episodes.
much of 2 episodes, very very minimal, not very sure. No, did she have any lateralizing?
No.
Nothing. It was only 2 episodes of dysarthria. Since the patient is known to have a carotid stenosis, and whether to decide. So, what is the indication for doing DSA in this?
She was already having a lesion and recurrence of symptoms. Even on
So, as we
medication.
discussed earlier, one is to, you know that the patient has got a left carotid artery stenosis. So, you have to know 2-3 things. One, whether the lesion the stenosis has progressed or not, whether it has gone into, the stenosis has increased. Second, whether there is a risk factor for the stenosis, like a plaque rupture to a superadded thrombus in that, or whether it has gone into a total occlusion. All these are possible. So, in such a situation where the patient who is known to have a carotid stenosis comes with recurrence of symptoms on medical management, the ideal investigation will be to do a DSA. So, that will help us to decide, one, whether the nature of the lesion, whether that has become more symptomatic now, and what can be the appropriate treatment. For example, if there is a superadded thrombus, then the treatment will be anticoagulation. Attempting stenting in such a patient can be disastrous, or endarterectomy. If the lesion has progressed, then you have to decide, you have to look at the collaterals and see whether the patient is at a high risk, and then decide what's the best treatment. Now we'll come to, the patient underwent a DSA through the radial route. What is this?
Right radial.
So this is one reason why we say always do a angiogram before proceeding further. Here what do you see? There is a small kink here. If you enlarge it further, you can see that now there is a kink in the radial artery. When you take an angiogram, you know that there is a kink, and one has to very carefully navigate this area. Otherwise, there is a small chance that you can dissect or injure the vessel. This can be easily converted to a rod map, and based on that you can pass your wire easily without any problem. See that once the wire has passed, the vessel has straightened up, it is a clean vessel, the catheter went in easily, there is absolutely no problem. Now, from the CT angio image which we already have, we can easily make out this is the subclavian artery coming through the brachiocephalic trunk into the arch of aorta, and it is taken a curve and it has gone into the
Subclavian.
Yeah, probably into subclavian or into the left
carotid.
common carotid artery. We'll have to take a shoot and see, and then see what is happening. So it is the left common carotid artery. This is the intracranial view. Try to identify the vessel. This is the
Internal carotid.
this is the internal carotid artery. This is the
Petrous segment.
petrous segment. Always remember the petrous segment is very important for the interventionalist. You can park your catheter if you are doing an intracranial procedure. Park the catheter here, which is the stablest part. What is this dense area? This is the ophthalmic curve or the cavernous curve where the ophthalmic artery rises. Because it's a curve, this is an end-on view that produces this dark image, and this is the distal end of the internal carotid artery dividing into middle cerebral artery, which divides into upper division, lower division, and all the branches. Here is the A1, which is a very large A1. Why it's a very large A1?
They are supplying both.
Here it is supplying both sides. You can see that normally, suppose if you cut, this is the center portion. Normally, if it is supplying only one half, this ACA territory only should be filling. Here you can see that it is crossing to the opposite side and filling the opposite side also. That means here the ACOM is present here, the circle, part of the circle of Willis, and this A1 is supplying the ACA on both sides. So the problem is, this A1 gets occluded, the patient will have a bilateral lower limb weakness if the opposite A1 is completely aplastic absent. If it is present, then this will support both sides. This is part of the circle of Willis, this ACOM. Hope now you understand the significance of identifying whether the ACOM is present or not.
Yes, sir.
Understood? Now, what do you understand? What is the territories which is supplied by this carotid artery?
ACA and MCA territory.
It is supplying 3 territories. One, the MCA territory, ipsilateral ACA territory, and ipsilateral contralateral ACA territory. So 3 territories are supplied. Can a carotid artery supply more than that? Suppose if it is a fetal PCA, it can supply up to 4 territories. If there is a fetal PCA, that means the posterior cerebral artery territory, the anterior cerebral artery territory on both sides as well as the MCA territory can be supplied by. Why understanding this is important is because suppose if 4 territories are supplied by one carotid artery, a stenosis is very very significant. So it can vary. Suppose imagine the carotid stenosis is on one side where this A1 is hypoplastic and the whole thing is supplied from the opposite side. This carotid is supplying only the middle cerebral artery territory. So the risk is much lower. For example, when it is supplying 3 territories, the chance of a hemodynamic stroke is
Very high.
higher. This is the lateral view. So we'll try to identify the vessels. This is the carotid artery, and here you can see the ophthalmic and dividing into. Lateral is mainly used for reading the anterior cerebral artery and its branches. Here you can see one anterior cerebral artery and you can see the opposite anterior cerebral artery. So it's a two, as we have seen from the AP view, both the anterior cerebrals are supplied from the same side. Now let us have a look at the proximal carotid. So this is the proximal carotid artery, origin of the internal carotid. How much is the stenosis from this picture?
Almost 60 to 70%.
Yeah, it is not very tight, no. As we thought that it will be very tight. We thought that it would have progressed by this time. From 2019 to 2022, it would have progressed significantly over the 3 years. That is why she has become. But no, contrary to what we thought, the lesion has not progressed much. We'll take one more view in an oblique view and see another view where also you can see that it has not significantly progressed. It is a very clean lesion. It is not an ulcerated plaque. There is no feature to suggest that there is a super added thrombus in that. There is no super added thrombus is seen. It's a very clean lesion. It's not irregular, and it is not a very tight stenosis also. Another view. So when there is a doubt, you have to take in different views. Which is the view in which usually the carotid stenosis is clearly seen? It is in the lateral view, not in the AP view. AP view usually the external and internal will be lie one over the other, whereas in lateral view you can open up the bifurcation and see the stenosis much more clearly. So here also, when there is this is not what we expected. We thought it would have progressed much higher. It's a very tight stenosis, but contrary to what we thought, the DSA shows that the stenosis has not progressed much. Another view. Now we have to complete the other side also. This is how by the radial route we engage. You take the SIM catheter which goes like this. Just pull it back into the brachiocephalic trunk. Automatically, in most of the cases, it will hook the right common carotid artery. And this is, what is this image? This white image?
Road map.
This is a rod map. So under rod map guidance, you can easily pull the catheter back into the right common carotid artery. Right common carotid artery bifurcation is normal. There is no stenosis. It's a very clean lesion. This is the vertebral artery rod map. So when you pull the catheter back, take a shoot from the subclavian artery, you can get a rod map, and take a shoot now just to see how the posterior circulation is. Because we have taken the injection from the subclavian artery, the quality of the angiogram may not be very good, but we are not too much bothered about the posterior circulation. Now the last question, this is what we discussed earlier, was what has this lesion led to? Has this carotid stenosis produced any long-lasting effect in the brain? Is there a new infarct? So the MR which is done now does not show any new infarcts in the MCA territory.
Yes.
Always remember, this particular patient, the MCA territory is supplied by the carotid. The ACA territory here is supplied by the carotid. The opposite ACA territory also is supplied. So you should look in these 3 territories for any infarcts. Understood? If there are infarcts in any 3 territories, then you have to decide whether the patient needs treatment or not. Here the new MRI which is done, which does not show any new infarcts, and hence what should be the treatment?
Best medical treatment.
So ideally the patient has not progressed much. The symptoms are also very minimal. Maybe you can change the antiplatelet regimen to a newer antiplatelet like ticagrelor and see whether the patient, and keep the patient under follow-up. What do you think is the risk of this patient developing a stroke? Much lower. We can't say that the patient. And second is, what is the other important thing? Always when you think that just because the patient has got a carotid stenosis doesn't mean that is a cause for the stroke. Once in a while, you will come across patients who have atrial fibrillation and there is a carotid stenosis which is asymptomatic. So, always never forget to evaluate the heart for an atrial fibrillation or a cardiac source of embolism. That could be the source of embolism. Keep the patient under follow-up and then decide whether the patient needs intervention at a future date. But now the patient can be managed medically. Thank you for your suggestions and comments. Please do subscribe to this channel, and also if you find this useful and interesting, please do share with your friends who might be interested in stroke. Thank you, and see you next time with another episode of Cerebral Angio reading sessions from Stroke Academy. Thank you.